Welcome to the symposium, and I'm privileged to speak about the current therapeutic outcomes and possibilities in pediatric cardiac surgery. First, I would like to talk about a little bit about what pediatric cardiac disease, congenital heart disease is about, and highlight some demographic data and the surgical possibilities and the current outcomes and some future expectations. So how come that congenital heart disease come to the scene? That's dedicated to the heart's development, and the heart is the first organ in the body that actually starts functioning at the third week of gestation, even though that mothers may not be aware of the new babies coming. And the heart already starts pumping, but the heart doesn't really finish the development until we start using our lungs, and that gives a very long period for any obnoxious event, virus or anything to halt that development and result in a congenital heart disease. And of course, compared to adults, that's only 1 in 10 patients with a heart problem would present with congenital heart disease. It's quite a lot, actually. And another notion of difference is that when you are dealing with adults with coronary disease, as we heard, you can do a successful investigation, successful intervention, and that person goes back after a couple of months to work and actually will pay back what society invested in medical care and so. For the babies, it's quite different because when you deal with a neonate, that takes almost like 2 decades that that neonate can pay back what society invested to him. So that's a long-term investment for future. And when we look at the congenital cardiac patient population, we can say that about 80% of them are below adulthood, 18 years of age, and that patient population is actually growing, that become so-called adult congenital heart patients, thankful to the possibilities that we can treat them. Now, in these days, antenatal diagnosis and detection of congenital heart disease is becoming prevalent, and more about 3/4 of the cases we can actually prepare for a better planning, how those babies would be born, and we can avoid all those horrible stories that someone is born with a rosy outlook for life and all of a sudden decompensates, and we need to rush into the catheter lab or the operating room to save life. When we see a neonate with congenital heart disease, they come with a normal maturation because the heart is affected, but due to the peculiarities of the fetal circulation, actually all the body organs can mature, and those babies would have a very good outlook for life if we could do an operation, which they need around 55 to 60% of the cases during their lifetime, and 2/3 of those cases they would need surgery within the 6 months of life. Now, since the 80s, we try to fix all the problems with operations. So that's the unifying philosophy of our work. But unfortunately, that's not really possible in some of the patients when you have to go for stage repairs. But when we were discussing that this is a real life changer, these are what the data shows, that someone before congenital cardiac surgery had less than 20% chance to be alive at age of 18. Now this is more than 85%, even 90% in 2021. So that's a great changer. Most of our patients, as I mentioned, are either neonates or small infants, and we can do primary repairs of them. And then those operations are quite risky, unfortunately. when you look at the risk stratification, when we try to tabulate what those risks are, you can see that these 150 operations that we are basically doing in any combination of those 150 operations. So we deal with mostly complex or even most complex cases. Patients, they come in a very widespread age group, from a couple of hours of age even to the let's say elderly people around 60 or even more. They come with a different broad body weight, from a couple of hundreds of grams to normal adults, and that sets a great expectation for the entire team and also for the patients to be successful. The statistic shows that there is one cluster of patients, the neonates, coming for complex repairs, coming for emergent acute situations. But the good news is that the results for those patients are not significantly worse. Actually, not too much worse than even 95% survival we can achieve with those patients when you compare to the other patient groups. So it's definitely a good news. I would like to share one success story in our domain. This is a situation when you have transposition of the great arteries, when the two great vessels, they are wrongly arranged, and they are in a wrong connection with the ventricles. The one pumping chamber that pumps out the blood into the body is the right ventricle, that basically pumping out the dark blood, and the other one is pumping out the blood into the lungs. So in one circuit we have just circulating very dark blood, and the other one is very, very bright blood. And if there was no communication, these patients, they wouldn't have any chance to survive. Now, for these patients, there is an operation when we actually change over or switch over the great vessels by cutting them through, and then taking the coronary arteries out of the places and bring to the new places, and then connect the aorta normally, aligning from the left ventricle, pumping out into the body the fresh blood, and then we will connect the pulmonary arteries. And these patients, they actually go through this surgery very, very successfully, and they have a new life, a completely healthy outlook for a good quality of life. This operation, when it came into the scene in the mid-70s, early 80s, carried a high risk of mortality, around 10%, but now most centers can do this operation without, let's say, significant risk. So that's really a success story, and most of our patients, in other operations, we can do the same intervention. When we look at the modern trends, we can state that the time of the primary operation can be lowered. So even we perform these operations at a much younger age, but the risk still remains slightly higher. So there is other possibilities to deal with the surgery. You can see this is the incision for normal or classical cardiac surgery, but when we are dealing with less complex problems, we can actually do a couple of more cosmetically appealing incisions. Or you can see this patient had a cardiac surgery, open heart surgery, but you cannot see anywhere where the scar is. This is a good cosmetic result for a lot of patients. Or we can do something else. And this is an example for that, when you combine with the cardiologist the work and some parts of the operation, the procedure they do, some other parts we surgeons do. And in this patient you can see the stents that connect the arterial outflow from the heart, and also some part of the venous backflow towards the lung. With that, I already mentioned that the grown-up congenital patient population is actually growing, and probably in the coming years will exceed in numbers with the babies. So for those patients, we need to come up with less aggressive methods like stents and some implants. Whenever we can actually combine the efforts from the team from cardiologists, and that actually signifies the point of my talk, that pediatric cardiac surgery is actually at the crossroads of disciplines, and requires a lot of teamwork. It requires a lot of communication, and when we are expecting that pediatric cardiac services in Singapore will develop, this is what we expect, that we can create something like a continuity of care, the patients coming from the community, undergoing their procedures, and they going back to the community. So that takes a great teamwork, and you can see the NUH team is very dedicated and devoted to realize that teamwork, that based on transparency, that the public scrutiny is actually looking at the results that the team and the service can provide. Now, just a couple of words about the future of our work. As I mentioned, this is still quite an aggressive work, and I hope in the future these very aggressive operations will be obsolete. We can do prevention. We can come up even much better, much smaller, much more advanced devices that we can put. And of course, we hope that with new modalities like 3D printing that nicely gives you amazing, almost like artistic specimens and models of the heart, can help you to make cardiac surgery much safer. We also hope that with some robotics, we can actually achieve that someday we can send robots in the operative field that will do the surgery that we are doing in the field of the virtual reality. So all those techniques will give a new possibility and opportunity for these patients to undergo these surgeries much less aggressive and much more safe. And of course, we hope that new materials will realize that I would say holy grail in congenital cardiac surgery, that we would have an implantable valve that is living and is growing with the patient, and that will avoid the necessity that all those patients will undergo a couple of surgeries until they reach adulthood. So that will be the other half of that circle that brings patients to a new possibility to undergo. So I would conclude that congenital heart surgery really has life-changing effects. The results are ever improving. Work is very much based on a team effort, and we will see how the future will improve the safety and bring less aggressive procedures with the change of new modalities. Thank you very much.